Sue Chandra. Sue is one of our melanoma medical oncologists, has an interest in developmental therapeutics and clinical trials, and has really been a wonderful addition to our program and a clinical stalwart who takes wonderful care of her patients. So Sue, please start your talk.
Thanks, Jeff, and thanks, Sam, and to AIM to putting this conference together. And thanks to all of you guys for joining. I know it's hard to do this on a Thursday evening, so thanks for sharing part of your evening with us. So let's get started. I'm going to share my screen. Okay. I hope you guys can all see that. So today we'll be talking about side effects of melanoma therapies. Specifically, I'm going to really concentrate on the FDA approved therapies, and it's going to be bucketed into immunotherapies and then targeted therapies. So when we talk about immunotherapies, we're talking about Yervoy, also known as ipilimumab. It's the anti-CTLA-4 antibody. And then we're talking about nivolumab and pembrolizumab, which is Opdivo and Keytruda, respectively, with their brand names, and those are anti-PD-1 antibodies. So, the point of using these immunotherapies, as has been mentioned, is to activate the immune system. We want to activate T cells, so those T cells can actually find and kill cancer cells, specifically the melanoma cells. But activating those T cells is a fine balance of keeping the cancer under control, but keeping the T cells from affecting healthy tissue. And when I say affecting healthy tissue, that manifests in the state of what we call autoimmunity. Okay, so basically these activated T cells then start kind of attacking healthy tissue, which causes various types of side effects. And these side effects can truly affect each and every organ of our body. And, as many of you guys have seen from our clinic meetings and appointments, we go over this very extensively. Truly these immunotherapies can have widespread effects. And my goal today is to kind of give you a snapshot of some of those effects and hopefully to give you a sense of why we ask you guys the same questions over and over again when we see you in clinic, why we do the testing that we do, and why we take it so seriously. So the most common side effects with IPI, for example, are rash, as well as itching, diarrhea, fatigue. The next most common are probably the glandular dysfunctions. So for example, the pituitary gland in the brain, thyroid gland, the pancreas gland, as well as the adrenal glands. The rest on the screen are relatively rare side effects, but many people can still get them. And so it's important to be aware of it, to know, when to call, who to call, and to be really vigilant on any symptom that seems a little off. A rule of thumb that I use in my clinic that I tell patients is, look, we're all still at risk of getting colds and coughs and headaches and things like that. But anything that lasts more than what we would think would be normal, 2 to 3 days, just give us a call. Let us know so that we can look into it if we're worried about it. So with anti-PD-1 therapies, specifically nivolumab and pembrolizumab, the most common side effects, again, are rash, as well as itching, which is called pruritus, diarrhea, fatigue. These glandular dysfunctions can also come up. A little bit different is you can get some infusion-related reactions. So as you're getting treated, you can have fevers, chills, things like that, but that is relatively rare. And then you can also get inflammation in your lungs. It's known as pneumonitis. So the problem with these side effects is it's very unpredictable. I can never tell, who's going to get it. I can never predict when they're going to get it. Essentially, close follow-up is really essential, and we want to be very timely in acting on any side effect that we're worried about. So some things that we always think about in the clinic is, okay, this side effect, is this from the immunotherapy or is this something else? For example, if someone tells me that they're having diarrhea, my first question is it from their immunotherapy or did they have a bad taco last night, right? And so being able to differentiate that is very, very important because that's certainly going to manage how I then treat that that diarrhea. So then the next question is, do I hold immunotherapy? Can I continue it? Is the person on a clinical trial, which makes management sometimes a little bit more rigorous, more strict? We have to follow very strict protocol rules in those situations. Do we start steroids? Can we do pills? Do we have to do IV steroids? Does the patient need to be admitted? These are all questions that we start thinking about. And then finally, in patients who we've started steroids and may not have gotten as fast of a response as we need, the next question is, do I need to give them a stronger drug to decrease their inflammation? These drugs are called infliximab or Remicade, that many of you guys may have heard about, or vedolizumab and Entyvio that we often give for diarrhea, colitis, a drug called mycophenolate that we give for hepatitis that we can often use to help dampen that activated immune response. Now, what's interesting, though, is if you look at the data, patients who have an immune side effect, it's actually not a bad sign. In fact, it's a good sign. It shows us that their immune system has truly been activated by the drugs. So it's, I think, a good surrogate for the expectation that their cancer might be also responding to this activated immune system. So here, the blue lines on the left are patients who had an immune-related adverse event, IRAE, and those patients have a higher chance of survival than those who had none. Okay, now on the right, those who had an immune-related adverse event, if we had to give them an immunosuppressant, such as steroids or something else to dampen that activated immune response, those patients actually also their survival outcomes were better. So I think some patients get really anxious, understandably, that, oh my gosh, now I'm having a side effect. I don't want my immunotherapy to be stopped. But in reality, it's actually not a bad thing to have a side effect to these drugs. Same thing here. This is just showing that if we have to discontinue the immunotherapy because of a really bad side effect, their outcomes are really no different from people where we didn't have to discontinue their therapy. Again, all of this is showing that activating that immune response at the end of the day leads to better outcomes. Now, I'm going to give you some snapshots of some of these immune-related side effects that I have seen to hopefully give you a sense of, what we do when we, why we ask you all these questions and what we do with that information. So these are some pictures of patients who have had skin toxicities from immunotherapy. On the top left, at first the question was, oh gosh, this almost looks like a shingles because it was very vesicular, but it ended up being a dermatitis, a rash from the drug ipilimumab. On the top right, this is a patient who got scabs on their lips, and we did a biopsy of it, and it was a skin toxicity called lichen planus, again, resulting from the immunotherapy. On the bottom left, this is a patient who had a history of psoriasis, and their immunotherapy really flared their psoriasis. And by the way, this patient is actually doing really well. Many of these patients are doing really well. So don't let these side effects scare you. I'm just here to try to help you see some of the things that we worry about when treating with these drugs. On the bottom right, this is a patient who had vitiligo, so that whitish, depigmentation of the skin. It's a benign condition, but it's certainly something that we see with immunotherapies. Back to our patient with the history of psoriasis, when we did a biopsy under the microscope on the right, all these little purple dots these are basically this skin biopsy is chock full of immune system, chock full of activated immune cells. So, when we say, we need to do a biopsy, we need to look for what's causing this. This is what we're looking for. So both on the left and on the right, these are patients who have gotten immunotherapy who had bad colitis. So on colonoscopy, all these white patches that you see, they should not be there. There should be a nice pink colon. But all these white patches, these are ulcerations. These are basically, this is clear evidence of an immune-mediated colitis. And on colonoscopy, on the biopsy specimen, again, the biopsy specimens are chock full of immune cells. This is a patient who came to me with chronic headaches, and the headaches just would not go away. And so I actually I had her get a brain MRI, and the brain MRI actually shows this little gland that is highlighted here in this with this green ruler. This is the pituitary gland. It's kind of a P-shaped gland at the base of your brain. And here it's actually much bigger than what it should be. So in this patient, what we think happened is those activated immune cells basically entered the pituitary gland, caused it to get inflamed, caused it to enlarge, and basically shut down the pituitary. Now, the pituitary releases a lot of important hormones. And so for this patient, we had to replace those hormones in pill form. And compared to most of the side effects that I'll be talking about, these gland side effects are usually permanent. They're usually irreversible. So we have to put the patient on a supplementation for the rest of their life. And by the way, that enlargement of the pituitary gland is what was causing her headache. So when patients come to me with shortness of breath or chest pain, or, they tell me, oh gosh, suddenly I'm having trouble climbing a flight of stairs and things like that, I always worry about pneumonitis. So pneumonitis, if I do a CT scan of a patient with pneumonitis, these are all representations of how that pneumonitis can look. It's very variable. Okay, so we really have to put the picture together in terms of how it looks on the CAT scans and what the objective data is. So this is a patient who is a 56-year-old female with metastatic melanoma on ipi/nivo who suddenly presented with dyspnea, which is a fancy way of saying she was short of breath. She was lightheaded. We had to actually admit her to the medical intensive care unit, and she had respiratory failure, and she required oxygen. We got CTs. Now, on the bottom left, this is her baseline CT prior to starting immunotherapy. On the right, this is her CT after starting immunotherapy. Okay, so imagine this CT scan as me just slicing someone like an onion, and this is basically a slice of their lungs. And so this, these black areas are lungs, the middle is the heart and the blood vessels. These are the back vertebral bodies, and this is the sternum up top. So all these white patches in the lungs should not be there. Those are clear evidence of pneumonitis. So actually for this patient, we started her on high-dose steroids. Her symptoms improved pretty dramatically, fairly quickly. And then we actually had to give her a second immunosuppressive on top of the steroids. But then guess what? Her lungs went completely almost back to normal. And she continues to do great, and her lungs still look as good as they do now. So many of these side effects we can recover from. This is a patient who actually started immunotherapy back in early 2019. And then as you can see, if you look at their liver enzymes called ALT and AST, if you start from the right of your screen to the left, you see that slowly these numbers are creeping up. And this is a great reason as to why we wait for labs to come back before we start a patient on treatment. So all of you guys who are, sitting there and waiting for your labs to come back in order to get your infusion, this is the reason. So this patient actually felt fine, but suddenly, if you look, their liver enzymes just jumped up exponentially. So this was a clear-cut evidence of an immune-mediated hepatitis. And actually, the patient totally recovered after steroids and after a second immunosuppressive drug called mycophenolate. This is a very rare side effect, thankfully, but I wanted to kind of show you how subtle these things can sometimes be. A 61-year-old female with metastatic melanoma who was on ipi/nivo, who presented with some gait abnormalities. So suddenly she had some trouble walking. So we imaged her spine, and basically this is her spinal cord, this gray cord right here, okay? And these are her vertebral bodies. So this light gray line inside the spinal cord should not be there. So that enhancement was indicative of a state called transverse myelitis, which was causing her gait abnormalities. We gave her high-dose steroids, and then her spinal cord went totally back to normal. And by the way, now her gait is pretty much back to normal. So some questions that come up is, can I get immunotherapy again once I have a bad side effect? It really depends on how bad the side effect was. As medical oncologists, we never subjectively look at a side effect and say, yeah, it's kind of bad. We grade it. So there's very strict guidelines to say, how bad is it? Is it a grade 1? All the way to a grade 5, okay? And so if a side effect occurs, we grade it, and then we wait until it becomes the lowest grade possible, which is a grade 0, grade 1, and then we have to decide, can we re-challenge it? Is it safe? Is it worth the potential possibility of that side effect happening again? And in patients who have really bad side effects, for example, the patient with the transverse myelitis in our last slide, affecting her spine, affecting her spinal cord, in that situation, I'd be very hesitant to re-challenge them because those can be life-threatening. So next is targeted therapies. We'll very briefly go over this. So Dr. Sossman mentioned these therapies are available for patients who have BRAF when they have a BRAF mutation, which is about 40% of the melanoma population. And there's basically 3 doublets to choose from, okay? Now, essentially, there's a lot of skin toxicities that can happen. Now, interestingly, with these doublets is if you use a BRAF inhibitor by itself, these skin toxicities are actually more common. If you combine it with the second drug, which is what we do these days, these skin toxicities are actually less common. So this is called an actinic keratosis. These are keratoacanthomas. They look like horns coming out of the skin. This is actually a cutaneous squamous cell carcinoma. It's a type of skin cancer. These are new melanocytic lesions. They can actually form new melanomas in these patients who are on these therapies. A particular doublet of the 3 that we had mentioned can make someone very sensitive to UV exposure, so they can get really sunburns really easily. And then with MEK inhibitors, you can see a really bad rash. Okay. You can also see MEK inhibitor specific cardiac toxicity, which is why we often do EKGs. We can even do echocardiograms if we're worried about the heart. And on the right, it shows you an example of an ocular toxicity. So basically, if we look at a patient's retina, this is the patient's retina, okay? And so these gray circles right here and with the red targets inside of them, those shouldn't be there. Those are basically small areas where the retina has actually lifted a little bit because of fluid buildup. So on the right, this is another way of looking at it. So this is the retina, and it actually lifts up and fluid builds underneath it. So that's called serous retinopathy. Thankfully, these rarely cause any functional issues for the patient, and they're very easily reversible. And then, many of you guys may have seen Ahmed. He's one of our research coordinators come by and talk to you about see if you would be willing to participate in one of our studies where we're actually trying to learn from these toxicities. So if someone has a toxicity, if we look at their blood, if we look at their tumor, if we look at their actual biopsy specimen of their toxicity, what can we learn from it? Okay, so we have a way to try to capture this. And, this is just the tip of the iceberg. These are just, for example, these 2 immunotherapy receptors on the T cell, CTLA4, PD-1, which is basically ipilimumab, and then nivolumab and pembrolizumab, respectively. Those are just 2 receptors. I mean, there's a number of receptors that are being looked at just on the T cell, much less other immune cells that are actually being studied. So I think we have a lot to learn about this in the future. And I hope this gives you a sense of why we try to be as vigilant as we are. And I hope it encourages you to really be very forthcoming with your providers and your doctors as to what's going on, what symptoms you're feeling, because the sooner they know, the more likely they can fix it. Thanks so much.